Thank you, Art and Lois, and thank you all for the opportunity to talk with you today. My name is Matthew McHugh. I'm a professor at the School of Nursing at the University of Pennsylvania. My reaction to this, one is, this is fantastic work. I'm so thrilled that the way that the work group has been organized and focusing on different areas, including a dedicated and thoughtful look at a conceptual model. But I'm also going to start by looking back. As Victor Zhao mentioned, the National Academy of Medicine recently celebrated 15 years since the landmark report To Err is Human and the Quality Chasm series. What I think a key contribution of those reports was that patient safety was squarely placed as a property of organizations. And they advised that improving safety required fundamental organizational reform. The focus was on systems, and the call was for transformation of work environments. There are parallels with our work today. So, as far as the content of this particular conceptual model, I think they've really hit most of the notes that I would expect to be sung. A couple examples of things that I think might be worth calling out are workload, as well as autonomy and control under the organizational factors. Importantly, the model differentiates between individual and external factors. So I think that the most critical next step in thinking about the conceptual model involves thinking about the relationships between all these aspects, and especially between the relationship between individual and external factors. So right now, although I appreciate Art highlighting that they're already thinking of this, right now it is unclear how the elements in this model relate to one another. And each element appears to carry the same weight. I think the research suggests that that is not the likely way that the world is really working. And this has implications for research and interventions. So, for example, an intervention aimed at improving resilience, like the one that Mark presented earlier, it may be shown in a randomized trial conditions to be successful, but out in the real world, where the work environment really varies quite a lot, that same intervention may not work, especially in a toxic work environment. So thus, the benefits of improving resilience, an individual factor, may be conditional on or dependent upon the work environment, an external factor. And this kind of interaction is critical for us to consider. Christina Maslach, who's done seminal work in this area, including work on measures of burnout, in their framework, they identify that there's clearly an interaction between the individual and the external factors, and that it is a mismatch between the internal and the external that lead to burnout and ultimately have consequences for patients. They go on to say, and I'll quote here, "It is paradoxical that most interventions focus on individuals, since the research suggests that organizational factors play a bigger role in burnout." At Penn, over the past 3 decades, we've surveyed hundreds of thousands of nurses in over 30 countries, and we consistently find, no matter what kind of health system we're evaluating, the work environment is the dominant predictor of burnout for nurses. So there's potential to misguide research and interventions, and a lack of clarity about the relationship between factors may unduly stigmatize providers as well. So we know that individual factors can be strengthened, and they should be a focus of intervention. But I worry that we may be unduly stigmatizing these providers such that they feel that they don't have some core strength or some core trait in order to tolerate the conditions in which they're working in. I think that's a backwards way of approaching this. Thus, I think focusing on the work environment is the key place for us to move, and especially in relation to those individual factors, in order to see the transformation of work life that we all want. Another nuance to consider is the multi-level way in which burnout can affect outcomes. So what I mean here is, because we know that healthcare is very complex, it's tightly coupled, it is highly interdependent, there are spillover effects, so that even if a patient's individual provider is not themselves burned out, if that provider is working with lots of burned out colleagues, there may be consequences. So to close, I want to congratulate the Conceptual Model Working Group. And in the same way the Quality Chasm series called for and set in motion actions to create positive work environments, we now have the opportunity to continue that work and push for fundamental organizational